This parasternal long-axis view of the left ventricle and a normal heart clearly shows the anterior right ventricular wall, the interventricular septum, the posterior left ventricular wall, the right and left ventricular cavities, and the left atrium. In normal subjects, the anterior right ventricular wall is usually thin with a mass less than 1/6 of the left ventricle. The right ventricle is usually less than 1/3 of the diameter of the left ventricle in this view. This is a parasternal long-axis view of the left ventricle in a patient with pulmonary hypertension. We can see how the right ventricle is severely dilated and hypertrophied. The left ventricular cavity is small due to the chronic right ventricular pressure overload. This is a parasternal long-axis view of the right ventricular inflow tract of a normal heart, which shows the inferior portion of the right atrium and the inferior and anterior right ventricular walls. This view is useful to visualize the tricuspid valve and its anterior and posterior leaflets. It can be used for the calculation of the tricuspid regurgitant velocity in patients with an eccentric tricuspid regurgitant jet. From the parasternal long-axis view of the right ventricular outflow tract in a healthy individual, we can see the right ventricular outflow tract, the pulmonary valve, and the main pulmonary trunk. This view can be used to measure pulmonary annular dimension and assess the pulmonary valve. From the parasternal long-axis view of the right ventricular inflow tract in a patient with pulmonary hypertension, dilatation and hypertrophy of the right ventricle, dilatation of the right atrium, together with tricuspid annular dilatation, can be clearly seen. From the parasternal long-axis view of the right ventricular outflow tract in a patient with pulmonary hypertension, we can see the dilatation of the pulmonary annulus and main pulmonary trunk. The pulmonary valve, main pulmonary trunk, and branches of the proximal pulmonary artery are visible in the parasternal short axis of the right ventricular outflow tract. In the normal subject, these are thin-walled structures, and at most there is a trivial amount of pulmonary regurgitation. A parasternal short-axis view of the right ventricular inflow in a patient with pulmonary hypertension highlights the marked dilatation of the pulmonary artery and branches. However, this is not a sensitive measurement for detecting pulmonary hypertension. The parasternal short-axis view of the aorta and left atrium, shown here, provides similar information to that seen in the parasternal long-axis view of the left ventricle and the parasternal long and short-axis views of the right ventricular outflow tract. Specifically, the anterior right ventricular wall, the anterior and septal tricuspid leaflets, and the right and left atrium and the interatrial septum. In addition, it demonstrates the aortic, tricuspid and pulmonary valves simultaneously. The image shown here is taken from a healthy heart, but this view is extremely useful when assessing structural valvular abnormalities. In this patient with pulmonary hypertension, the parasternal short-axis view of the aorta and the left atrium clearly shows right atrial and ventricular dilatation and right ventricular hypertrophy. The short-axis view at the level of the left ventricular papillary muscles can be used to assess the eccentricity of the left ventricle. The eccentricity index is a measure of the degree of distortion of the left ventricle, and it can be calculated from the short-axis view at the level of the left ventricular papillary muscles. It is calculated by measuring the minor axis of the left ventricle parallel to the septum, D2, and the minor axis of the left ventricle perpendicular to the septum, D1, as indicated on this video in both systole and diastole. The eccentricity index is calculated by dividing D2 by D1. Normally, the left ventricle appears circular in shape, both in systole and diastole. This means that D2 is equal to D1, which gives an eccentricity index of 1. In pulmonary hypertension, a pressure-loaded right ventricle results in a shift in the septum towards the left ventricle during systole, giving a characteristic D shape of the left ventricle. In severe pulmonary hypertension, The septum may even lie within the left ventricle itself, as can be seen in this short-axis view at the level of the left ventricular papillary muscles. The flattening of the interventricular septum towards the left ventricle results in D2 being greater than D1, which results in an abnormal eccentricity index that is greater than 1 in both diastole and systole. The eccentricity index is a measure of the degree of distortion of the left ventricle, and it can be calculated from the short-axis view at the level of the left ventricular papillary muscles. It is calculated by measuring the minor axis of the left ventricle parallel to the septum, D2, and the minor axis of the left ventricle perpendicular to the septum, D1. The eccentricity index is calculated by dividing D2 by D1. In the apical four-chamber view, structures including the right and left ventricular lateral walls, the tricuspid and mitral valve, both atria, and the interventricular and interatrial septa can be seen. It is also usually possible to assess 3 of the 4 pulmonary veins draining into the left atrium. In the normal heart, the right ventricle appears triangular in shape and about half the size of the left ventricle in this view, with its apex closer to the base of the heart than that of the left ventricle. In pulmonary hypertension, the right ventricle dilates and hypertrophies in response to pressure and volume loading, as can be seen in this apical four-chamber view. The subcostal view shows the right and left atrium and the right and left ventricle, the right ventricular inferior wall, the anterior and septal leaflets of the tricuspid valve, and the anterior and posterior leaflets of the mitral valve. The subcostal view allows for the estimation of the right ventricular function, especially in patients with difficult parasternal or apical windows. It also provides the best view for the measurement of right ventricular inferior wall thickness. In a normal individual, the right ventricle appears to be normal in dimensions and wall thickness. In a patient with pulmonary hypertension, the subcostal view clearly shows right ventricular dilatation and hypertrophy. From the subcostal view, we can also visualize the proximal 3 to 4 centimeters of the inferior vena cava by rotating the probe anti-clockwise. The measurement of the inferior vena cava diameter should be made at end expiration and just proximal to the junction of the hepatic veins that lie approximately 0.5 to 3 centimeters proximal to the ostium of the right atrium. The change in diameter of the inferior vena cava at rest and during inspiration, known as respiratory collapse, can be used to give an estimate of the right atrial pressure. It is explained in more detail in video clips 13a and 13b.